Hello, my name is Mark Sonnenmoser. I'm a student at Excelsior College and the manager of a trauma program at a designated Level 2 trauma center in the Midwest. My job involves responding to trauma alerts, some of which are high level or Level 1 responses. Some are lesser acuity, known as Level 2 responses. I also do an initial performance improvement review of all records that become part of the trauma registry. That includes all admitted, transferred, and expired trauma patients. The latter piece allowed the author to have a high-level perspective of key processes, what went well as what did not. The trauma management staff identified a number of patient safety issues. These issues were not so much clinical skills as processing issues. For instance, how does one identify those trauma patients needing the greatest level of resources? This was the Level 1 alert process. How does the team prepare for patients needing massive transfusion prior to the arrival of the patient? This was a trauma alert registration process. What is the best way to ensure comprehensive diagnostics in a timely manner? This was the use of the Level 1 and 2 order set. How does one determine the need to accompany a trauma patient during imaging? This became the Level 2 timeout process. How does one communicate critical information during the resuscitative sequence? This was SBAR communication. How does one mitigate a situation where patient harm is imminent? This was the use of an escalation procedure. The most affected group by this unit of instruction by far are those patients cared for by the trauma team. There were duties both explicit and implied to provide the safest possible care, as noted by the American Nurses Association in their Code of Ethics for Nurses. This project was rooted in safety concerns for this group. The second group of stakeholders were the emergency department nurses. Their pivotal role in key behaviors, as seen on the last slide, has already been noted. Closely related to this are the emergency department licensed prescribing providers, most of whom are physicians. The most prevalent cultural component was the relationship between the nurses and the physician. It was often defined by a bounded autonomy state of deonance, or morally prescribed role on the part of the nurses. This was countered by reactance, the choices inferred by a diagnostic differential on the part of the physicians. The problem was that this could produce a sort of role-lock state, as demonstrated by this slide. This particular exchange was actually used in one of the simulations that we used. Patient safety, therefore, became a casualty of this communications failure. The author's role was to determine the learning needs that would provide a solution to this problem, as well as other trauma processing issues. This was accomplished through three different mechanisms. The first was a role that was both observational and participative, responding to trauma team activations. The second was more reflective, based on daily performance improvement reviews of trauma events. The third was again reflective, but also case-based, in the form of debriefing discussions done with nursing staff, as well as the trauma registrar staff. This latter group also responded to some of the activations. This entire process, as well as reviewing pertinent literature, provided the basis for the curriculum. Literature reviews started with the relevant standards or policies of the organization. Both of the standards listed here were up for review at the time, so this was a great opportunity. The activation criteria and Level 2 timeout were both part of these existing standards. The second class of literature concerned the trauma team. The Emergency Nurses Association, through their Trauma Nursing Core course, provided a good review of team dynamics in their second chapter, although the focus remained almost solely on nursing. The online presentation by the Montana Department of Public Health and Human Services discussed trauma management from a team perspective. It was one of the few trauma-based resources to emphasize interprofessional training and the need for situational awareness, both of which became key during the simulation training. The latest version of the Resources for the Optimal Care of the Injured Patient by the American College of Surgeons was relevant in that it provided the basis of trauma team implementation in most places. However, there is not much emphasis on team functioning outside of the physician roles. The third class of literature focused on roles in communication. The first one, by Farrell, Payne, and Hyde, described a positive experience with interprofessional learning, how it assisted the socialization of advanced practice nurses. The second, Hans, Reed, Meredith, Smith, Pritek, Smith, and Featherstone, described an experimental reason for the failure to use an escalation protocol, primarily because the subjects fell back on their prior training. And then Nielsen, Erickson, and Borg's work described how predefined power and authority relationships got in the way of effective communication and collaboration when implementing new strategies. The role of the author in developing the program is best noted in this slide. Various stakeholders, such as the trauma medical director, emergency department medical director, multidisciplinary trauma team, emergency department management, and hospital education department, all had a decision-making role in the training. There was also a fourth category of literature that became relevant. Hastie, Fahey, and Parrott demonstrated a means to evaluate peers in terms of their team attributes, while Patterson and Grenny, in their noted influencer books, talked about ways to influence others for meaningful change, primarily by looking for key behaviors and then developing a series of strategies to address what were complex and intractable problems. Smith and Woodworth talk about social entrepreneurship and showed through case studies how students became involved to get a desired result. This program has been iterative and developed incrementally over the course of this particular education. There was a clear plan at the beginning that was developed from a presentation that introduced the key behaviors. The plan remained the same, but the program was modified with feedback along the way. The modification came first from other instructors, known as qualified evaluators or QEs, 6 of whom gave feedback on the material. Low fidelity simulation was used because for most of the training, nothing else was available. But it was also determined that low fidelity simulation worked best when developing effective communication skills, and this was noted by the Johns Hopkins School of Nursing in their Sim Stories videos. Much of the didactic material was fed into an online web quest. The introductory presentation and a video demonstration of a simulation both became YouTube videos. The latter video also represented the final training exercise. Supporting documentation, such as standards, were also placed on the web quest, and there was also a rubric tool developed. This was a modification of the Clark simulation tool. The QEs also gave feedback on this tool. The qualified evaluators were also able to establish some level of reliability, as per Orman and Gaverson, in their reviews of both the sims and the rubric. During the first simulation groups, there was also immediate feedback concerning the effectiveness of the sims, and adjustments were made. For the first outcome, or objective rather, there was actually a very simple informatics solution to this objective that was pre-planned. This was an EHR, or electronic health record, hard stop. That is, when the trauma documentation form was initiated, all level 2 alerts required this information to be documented. However, without the patient's safety rationale that was given in the training, this would have been a meaningless activity. Trauma alert registrations also were observed to be at 100%. Use of the level 1 and 2 order sets has improved to greater than 95%, which actually started out at less than 25%. And diagnostic completeness is typically achieved even when the order set is not used, as this has become an ingrained behavior on the part of all staff. Under triage, level 1 activations occasionally occurs after the training, but we do not have enough data collected on this item yet. We have had at least one near-miss event in this category. That event points out also that the escalation procedure was not used properly. These two outcomes carry the greatest patient safety risk with their failure. SBAR usage also is very much in the preliminary stages of observation, so we still need to get more data on that one as well. As mentioned above, this program was very iterative in all of its parts. Because of that, some staff received their simulation training prior to viewing the web quest and some afterwards. This allowed a comparison of the two groups. The education rubric allowed for 90 points total, with 70 points being the minimum needed. Those who viewed the web quest before their simulation, albeit a smaller group, scored 5 to 10 points higher on the simulation rubric, and none required remediation. There was also a noticeable difference between staff who had experience at what the author subjectively evaluated at the expert level versus those with a couple of years experience or less. Those expert staff moved almost seamlessly from SBAR communication into escalation when patient harm seemed imminent. There was no second guessing the actions to be taken. Likert scale results by the students was used to evaluate the program overall as well as their progress against their objectives. While there was no way to correlate a particular student's ratings, the objectives with the weakest ratings on the Likert scale corresponded to those that received the weaker ratings on the simulation rubric. Those were identification of level 1 alert criteria and using the escalation procedure. From a purely mathematical perspective, a Likert rating for an objective at 4.83 or above seemed to have criterion validity and seemed to support construct validity, while the lower scores did not. This presentation included some material not in the paper, as the author's mentor's evaluation occurred after the paper was written. Notably, the mentor felt that the preliminary evaluation results paired with the Likert ratings indicated a need to increase the weight given the objectives for identifying level 1 criteria and escalation procedures. Those objectives needed more stringent evaluation criteria and probably more attention during training. Other outcomes for the author were the use of an evaluation by the instructors, the QEs, to establish a reliable instructional program, and the use of student evaluation tool, that being the Likert scoring, for the program. Also, while the program was designed to assist nurses, especially novice nurses, it was noted that more novice nurses continuing to enter this particular workforce. Finally, the physician involvement in the program has been lacking. The weakest outcomes were the ones where physician mediation was common. This denounce-reactance relationship persists, especially when nurses are less experienced. The mentor suggested going back to those physician stakeholders to get their involvement in future training. For a variety of reasons, the program must enter yet another iteration. Thank you for your attention to this program. The next 3 slides show the references used for this presentation. I would like to acknowledge the invaluable assistance of my mentor, my classmates, my instructor, MAT, and also the kind assistance of the emergency department staff at Mosaic Life Care for their participation in this educational endeavor. Thank you.